The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone, and welcome to our webinar today. I'm Tom Glinsky, Chief Inspector with the Board of Pharmacy. Today I have with me Inspector Joe Dino. He is our inspector that covers the central Missouri part of the state. Thanks for joining me today, Joe.
Thanks, Tom.
Today's webinar, we're going to discuss automation regulations. But before we get started, I'll go over some of the general items about our webinars. All participants are in listen-only mode. If you have trouble listening over the internet, on your GoToWebinar toolbar, you have an option to dial in using the phone number and the access code they provide you. This program has been approved for 1 hour of CE. To get CE, you must officially signed up and logged in via your computer. If you're only dialing in on the telephone and not watching on your computer, you do not get CE credit. You must complete the survey at the end in order to get CE. We'll go over more instructions at the end of the webinar. And the CE is not submitted to the CPE monitor. We have handouts posted on the board's webpage. It's on the main page under the announcement of the webinar. There's a link that says handouts if you want to print them. We do post the recording of the webinar in 7 to 10 days. It's actually on YouTube now. There'll be links on the board's webpage. They can be found under the Publication Resources tab and then scroll down to the video webinar section. Unfortunately, at this time, you do not get CE for watching any of the recordings. At the end, if we have time remaining, we will take questions from participants. If you'd like to ask a question, go to your toolbar, type in the question, and hit send. Again, we will answer those at the end, but you can submit them anytime during the webinar. Okay, we're going to get started. The objective today is basically to go over all the automation regulations. We have basically 3 of them, and then specifically talk on some of the newer ones, the new automated filling systems rule, and then the new pharmacy classes that are related to automated dispensing systems. And then, as I said, we'll take questions at the end. This is the order we're going to talk about them today. We'll first talk about vacuum tube drug delivery systems, and then we'll go to automated dispensing systems. Throughout the webinar, I abbreviate that ADS. The ADSs are broken down. The rule talks about 2 different types, ones that are used off-site, and then those are broken into ambulatory care settings and healthcare facility settings. And then there's a type used in a pharmacy. It's an automated refill patient self-service device. And then lastly, we'll talk about the new automated filling systems, and they're abbreviated AFS. So vacuum tube delivery, there is a regulation covering these systems. It's 2.800. This regulation was promulgated in 1999, so it's been around a while. It's pretty brief. It says that if you're using a vacuum tube delivery system, it needs to go direct. It's delivery of prescriptions to the patient. The system must be secure, and it must get it to the right patient. It's dedicated to pharmacy use, so if you're in a grocery store and you had a bank location in your grocery store along with the pharmacy, you both can't share the same delivery tube system. The one for pharmacy is dedicated only to pharmacy use. The tube must go directly to the patient. That can't be intermingling with other departments if you had such a system. To use, a pharmacist must be present in the pharmacy just like anything else. Any other times, in order to sell a prescription, the pharmacist must be present. You must have audio capabilities with your tube system, and if you do not have a direct line of sight to the patient, you must have video capabilities also. And the offer to counsel is still required on a vacuum tube system. So that's done verbally through your audio system. These have been around a long time. We've seen different kinds, and we pretty much, the only problem I've ever seen with a vacuum tube is the video and audio systems are not working correctly. If they're not, you cannot use your system. I've actually been to a pharmacy where we told them they needed to shut it off until it was fixed. Audio problems, usually it's just static, so much static from the outside that you can't hear or understand what they're saying. And video, the quality is so bad due to backlighting or lighting issues that you can't see who you're talking to. So those are main issues we've seen compliance-wise with vacuum tube systems. I'm going to move on now to automated dispensing systems, ADSs. There's a rule, it's 2.900, called Automated Dispensing and Storage Systems. This rule was promulgated in 2001. I'll tell you, our first ones were about a year and a half ago. It was the first automated dispensing systems that became licensed with the board. So the rule's been around over 10 years, and we've never had one in operation in Missouri. The rule is split into two types, as I said previously, off-site and then a refill system that's used in the pharmacy. The off-site dispensing systems we'll talk about have new classes. We'll talk more about those. The Class O is for ambulatory care settings, and Class N is healthcare facility settings. And then we'll also talk about the patient refill device. So right now we'll talk about the ambulatory care setting. To my knowledge, we do not have any of these operating in Missouri. These are systems that are off-site, totally controlled by the pharmacy. Everything coming out of them are being dispensed as prescriptions to patients. The systems are fully automated, which means once the system is loaded, there's no other human intervention or manipulation during the filling process. So once the pharmacist at the pharmacy submits the data to it, the machine will process the prescription, and it comes out ready to go to the patient, all labeled, sealed, and ready to go. What these systems are not, they're not systems that just store office stock or floor stock for practitioners' use. An example would be like a cabinet type automation system where a healthcare professional goes up and goes in and gets what they need out of it. These systems are fully automated, unlike the cabinet systems that take a human in order to go retrieve the product out of it. These systems are also not automated physician dispensing systems. There are physicians' offices and clinics in Missouri that operate automated dispensing systems. They are operated under Board of Healing Arts rules under physician dispensing. A pharmacist is not in control of the system. There's no prescription being dispensed by a pharmacist. This is all being run by the physician's office. They enter the data into it, and this machine kicks out the filled prescription for the patient. There may be a pharmacist connected to it to provide counseling, but that's pretty much the only role the pharmacist plays in it. These systems, as I said, are not the systems that are regulated by the Board of Pharmacy. So an ambulatory care setting, what I've done in the webinar today, I'm going to talk specifically about the two setting types requirements, and then I'm going to go later on into the general requirements that apply to both settings. So for the ambulatory care settings, excuse me, Again, it's controlled by a pharmacy. A pharmacist has to do the verification of the prescription, and everything's being dispensed by a prescription. So back at the pharmacy, there is a prescription being logged into the computer system. It's assigned a prescription number, just like any other prescription that would be filled. These systems can only be located in prescribers' offices and clinic settings. They cannot be put in like a grocery store or any other type of facility. We get requests to people wanting to know, can I put in a automated dispensing system in the town next door that does not have a pharmacy? The only place automated dispensing system can be is in a prescriber's office or clinic setting. So it cannot be in a grocery store or shopping center. Inside the prescriber's office or clinic, it must be in the area that's utilized for provision of care. So it can't be out in the lobby. It can't be out in maybe a general lobby of a medical building. It must be in the area where physician staff are actually seeing patients. So it's going to be out of the public area. These types of machines can only fill prescriptions from prescribers that are located at the site. Again, this is a question we get about a pharmacy who wants to put one in a neighboring town. There's multiple physician offices there, and they want to know, can I use it to fill all the prescriptions from that town? The answer is no. You would only be able to fill prescriptions from practitioners at the site where it's located. Because of these two requirements, I believe that is why we find we don't have any of these in Missouri. It's pretty limited on where you can use these. The remote location is going to need a Class O permit. That's for the machine itself. And the pharmacy that's controlling it and the off-site location are going to need Class J on their permit. Other requirements, the system must be fully automated. Like I said, once it's loaded, it cannot, no other human manipulation goes on after that. So when the product comes out, it's ready to go, sealed and labeled for the patient. The system must provide audio and video communication in order to provide counseling. It must be located in a private consultation area. So it can't be out in the general public area. It needs to be a private area. And the label that comes out of this type of system is required to have the name and address and phone number of both the pharmacy that's controlling it and the remote site. So it would have the address of the clinic and the phone number for the clinic on it also. I'm now going to switch to the other type, and this is a automated dispensing system located in a healthcare facility. To date, we have, I think, anywhere from 15 to probably 20 of these located in the states. They're all located in long-term care facilities is where we see them. The rule requires that the facility be licensed, so these would be licensed. The long-term care facilities we see them in now are licensed with the Department of Health. It's possible you could be at a Department of Mental Health license facility also. But those are the two licensing agencies that come to mind where these may be located. It requires a Class N permit at the facility address. So the long-term care facility is going to have there's going to be a permit at their address, but it's going to be under the pharmacy's name because the pharmacy is the one controlling the machine. One permit will cover all units at a facility. So if you're at a large long-term care facility that had multiple units, we would allow one permit cover all those units for that address. These systems can be a cabinet type or a packaging type. A cabinet type would be more of what we see at like a hospital type system where the nursing staff goes and retrieves the product out of it. The packaging types are systems that actually package it and kick it out ready to go. The ones I've seen so far do multi-med pack dispensing. So at the long-term care facility, the machine kicks out like a pouch, a sealed pouch with all the meds for, let's say, the 8 o'clock dose pass. And so that's the system so far we've seen, I believe, are all packaging systems. Similar to the Class O types, these are controlled by a pharmacy. Everything's being dispensed by prescription. So a pharmacy that's controlling it is generating a prescription, have a prescription in their files at that pharmacy. A pharmacist is required to verify and approve the prescription before the initial release. However, once it's been initially verified, subsequent release of product from the machine does not require pharmacist verification unless there's a change to the prescription. Emergency kits, we get a lot of questions about automated emergency kits and how they are they automated dispensing systems. They can be, but they don't have to be. An automated emergency kit provides medication for emergency administration by the long-term care staff to handle emergency situations. A automated dispensing system at a long-term care facility can be used for both emergency kit and for continued therapy. We allow it to do both. If you have an automated system and it's solely used as an e-kit, that does not fall under our rule. What triggers our rule is the continued therapy on the e-kit. So we are aware there are some automated e-kit systems out there. They do not fall under this rule. It's because they're only treating the emergency situation. Some things to consider with an automated dispensing system at a long-term care facility. It deals with the Department of Health. The Department of Health regulates the activity of the long-term care staff there. So they have rules and regulations on how the drugs are given. But the board's rule covers the machine itself. So once after it kicks it out to the staff, Department of Health rules would take over on that. The Department of Health, my understanding is their rules currently require that all drugs at a long-term care facility be labeled with a prescription label. Well, these systems do not label it with a true prescription label, so my understanding is the home has to request a waiver from the Department of Health in order to use one of these systems. So again, if you're thinking about putting one of these systems in, you need to be coordinating with the facility and with the Department of Health to see if there's any waiver requirements needed. There's also a different type of exemption. There are a couple machines in Missouri that the Department of Health has exempted them from requiring anything coming out of them to be handled as a prescription. Basically, these systems operate more like a hospital type setting where the drugs belong to the facility and no prescriptions required. Everything comes out of the systems, but not as a prescription. I think there's 2 or 3 of these in Missouri. The only pharmacist involvement is the Department of Health does require a pharmacist to review the order before anything comes out, which would be similar like happens at a hospital. These systems are, the controlled substances in them are under the long-term care. They would have their own DEA number and BNDD registration. The pharmacy is basically just acting as a distributor if a pharmacy is supplying the meds for this. Our rule does not apply to these few systems that are out there. Now I'm going to talk about general requirements that apply to both types, the N's and O's systems. On the permit itself, the name of the pharmacy is the one applying for the permit, but it is going to be at the address of where the system is located. So at a long-term care facility, it will be the long-term care facility's address, same with if it's at a physician's clinic. For the permit on the ADS permit, it has to be a Missouri licensed pharmacist in charge. The pharmacy controlling the unit must be Missouri licensed also. It can be out of state, however, it would require a non-resident license with us. There's a requirement for the pharmacy name and toll-free number to be on the unit itself. This is so people can see the long-term care staff or the public at one that's at a clinic. The rule says the pharmacist cannot delegate control of this other thing, so a pharmacist cannot allow a technician to be releasing product, doing any kind of final check, but we don't allow that in any pharmacy, but the rule does specify no delegation. There is a limit on the number of automated dispensing systems that one pharmacist can control or supervise. The rule says 3. There isn't a built-in exemption process that if you request to the board may grant an exemption to that. Some of the systems, some of these long-term care facilities do have they're controlling more than 3. With the number of pharmacists there, they have had requested the board give them an exemption, and the board has allowed that to happen. Other general requirements: the system must be secure and must provide drug security. Most of the systems are all locking. They track who goes. You have to have a password to get in and out of them, and it tracks all that. The system also must guard patient confidentiality. It's required to have records. It has to track all access events. And then the pharmacy that's supervising it has to have prescriptions for everything that's being dispensed and record all the transactions also. There is a requirement that if you have stock control substances in a automated dispensing system, the system must have a perpetual inventory system on those controls. The rule requires a quality assurance program for these systems. The assurance program must monitor and document such things as breach of securities and system failures. That would include dispensing errors. It requires any breach of security to be reported to the Board of Pharmacy and other agencies. Any loss of controlled substances, there would be DEA and BNDD loss reports having to be filed. The quality assurance program also requires testing of the system. You have to test it prior to use, and then every 6 months after that you have to run some sort of test to make sure it is dispensing and labeling the correct product. And you have to do it prior to use after any change or modification or upgrade to the system. You're required to document all these testing and any of the breaches or system failures. You're required to document that and have it available on any inspection. Restocking. These systems can only be restocked by persons licensed by the Board of Pharmacy, so it would be pharmacist, technician, or intern. At a long-term care facility, registered nurses, LPNs, none of them are able to restock the system. Now, we've had questions before, can we license like an RN at a home so we can send the meds and have them restock it? Yes, you could. They would have to go through the same technician registration process, but you can license staff at the long-term care site. The others, what we typically see is a pharmacy sends their own staff out to restock. The other thing about any meds that come out by mistake or errors or a patient no longer needs, staff at the site cannot reload those back into the system. Only Board of Pharmacy licensees can do that. Repackaging. Some of the systems use container type systems that are repackaged at the home pharmacy. Any repackaging has to be done in compliance with our repackaging rule, which is 2.130. Basically talks about labeling and expiration date. Expiration date is 1 year from the date of repacking or less if the manufacturer's original would be less. All repackaged product must be checked by the pharmacist. It has to have some secure tamper evidence system, so it's known when someone goes out that it hasn't been tampered with. And the automated system must use technology to ensure accurate loading. So most of them have a barcode system that scans what's loaded to make sure the right product is being loaded. These systems require policies and procedures manuals. I have just did some topics. I would recommend you go to the rule itself and look what's actually required. The topics include security, limits on access, patient confidentiality, data retention and retrieval, emergency first dose procedures, system maintenance, inspection of the system, inventory control, quality assurance, training of the staff, that's both pharmacy staff and the long-term care staff or the clinic staff, handling system malfunctions, if a system's off, is there procedures in place so people can still at the home receive their meds, how wasted or discarded medications are handled, and if controlled substances are stocked, the perpetual inventory. Just some cautions about automated dispensing systems. The ones we've seen so far are doing multi-med dispensing. Again, besides the automated dispensing rule, all multi-med has to comply with the board's standards for multi-med dispensing. That's regulation 2.145. So you want to make sure you're in compliance with that. If your units are stocking controlled substances, they're going to require their own registration at those sites. I encourage you to contact BNDD and DEA to find out what the requirements are for that. If you're putting a unit in a licensed facility, such as a skilled nursing facility, I check with the licensing agency to see what kind of requirements they might have. And if you're using an automated dispensing system for any type of outpatient dispensing, that would fall under the Board of Pharmacy's requirements, regulations, and rules if it's used for outpatient dispensing. There is a scenario where a system could be at a hospital that would not fall under RU. It's when the pharmacy is not available and a system is dispensing a limited supply until a pharmacy is open. I believe we still have one of those operating in Missouri. That system is basically more similar to a physician's dispensing system, and it's not regulated by us. However, I will caution you, if you exceed the supply limits of what Department of Health allows to be given out when the pharmacy's closed, then it would become true outpatient dispensing and would be regulated by the Board of Pharmacy. What's not allowed, we get a lot of questions about remote supervision of technicians. There are some states that now allow remote pharmacies that are run by technicians that are being supervised electronically. Missouri does not allow that. We also do not allow remote pharmacist verification of final products. The automated dispensing rule has another type of device included in it. This was added probably 7 to 10 years ago. The board was approached by a company in a pharmacy who wanted to put in a self-service device in the pharmacy that would allow a patient to come up, basically more like a vending machine type system, where a patient, instead of going to a pharmacy counter and talking to dealing with a human, it would go to a automated system that would allow it to pick up a refill that's already been dispensed and loaded into the system. I do not believe the pharmacy ever put this in. I've never seen one of these in Missouri, but it's still allowed. The board inserted different requirements in the automated dispensing rule. I will tell you honestly, this rule is hard to read because it's got 3 different types of systems intermingled throughout. Hopefully at some time we will rewrite the rule and separate all the systems into their own rule to make it easier to follow. But throughout the rule it talks about a self-service device, and this is what it's talking about. The requirements are it must be physically attached to the pharmacy. It must provide drug security and patient confidentiality. The restocking of it access area has to be in the pharmacy area, so it can't be out in the general public area where this machine is and you go out and reload it out there. The reloading has to take place back in the pharmacy area. So these systems are located right up next to the pharmacy. It can only be used for refills. The pharmacist must be present just like any other pharmacy when any prescriptions are sold. You must be able to meet drug storage requirements. So you cannot, if the system does not have a refrigerated compartment, you can't put product that requires refrigeration in there. You cannot put product that requires further manipulation, such as an antibiotic that needs to be reconstituted. This is the one time where the device may offer the counsel. It may provide that to it electronically. In all other instances, it must be a verbal offer. And it does require a policy and procedure manual. Like I said, I don't think we have any of these in Missouri, or at least that I'm not aware of. Just a refresher on what the patient counseling requirements are with these types of systems. The refill patient self-services device, that device may make the offer to counsel. Ambulatory care setting and automated dispensing system, there must be a verbal offer via the audio system. And at the healthcare setting, a Class N, it's actually not required for nursing home residents because there are other healthcare providers administering the drugs for them. Talk briefly here about the new permit classes. We created these classes to help us better identify where these units were and what type of units they were. Class N is for the ones located in a healthcare facility, the long-term care setting. Class O is at an ambulatory care setting. These permits classes belong on the permit at the off-site location. N's and O's do not belong on the permit of the unit, of the pharmacy that controls the unit. I will tell you, during the last renewal period, all pharmacies had the opportunity to add these to their license during renewal time since it was new classes. I say we didn't do a very good job putting out guidance on what these were. We had probably 30 or 40 add them to their license that I've talked to probably 2/3 of them that don't need it. I'm still in the process. So if you have N and O on your license and you haven't heard from me, you probably will in the next month or so. Trying to find out if you really need one. We had a lot of people put it on it for thinking that the robot they use in the pharmacy needed a automated permit. So if you have N and O on your license, have any questions on if you need it, you can email me and I can communicate with you. If not, I will be reaching out to the others I haven't talked to yet. You do not need a Class N and O permit for a unit that's being used solely for inpatient activity within a hospital, or a unit being used inside the licensed premises of a hospital. So let's say you had a clinic inside your hospital and you had some type of unit in there that wouldn't be covered, you would not need the permits. At a long-term care setting, you do not need a permit if it's just an e-kit providing emergency. It's the continued therapy that triggers the need for the permit at the long-term care facility. No permits required for a physician's office who's using a system for true physician dispensing, and you do not need permit classes if you have some type of automation that is storing office or floor stock for health care practitioners. Examples is a lot of the hospitals have off-site clinics. They may have some type of automation there that is storing the floor stock or office stock. That is not the type of unit that needs a permit. I'm now going to move over to automated filling systems. This is the brand new rule that the board just took effect this year. I'll give you a little history about automated filling systems. In the past, we called them robots. The first ones, probably well over 10 years ago, the board was approached by pharmacies. Actually, I think the very first one was a hospital. Approached the Department of Health and the Board of Pharmacy wanting some guidance on the checking of these units. The board's regulation for outpatient requires a pharmacist to verify the contents of the label of any prescription that is filled or prepared by a non-pharmacist. The board made an interpretation probably about 10 years ago saying that on a robot system, an automated system, that if the pharmacist checks what goes in the system and there's no further manipulation during the filling process and of the product when it comes out, that a pharmacist did not have to check the final product. And the board has been operating under that interpretation for at least 10 years now. The systems the board was talking about are ones that the product comes out completely ready to go. There's no other human manipulation of those. An example of one that didn't qualify is there's a system where the bottle comes out labeled but there's no lid on it. So it requires a human to put the lid on the vial. So that never did qualify for the board's interpretation. The board was then approached by a couple pharmacies that use automation, and as automation and technologies advance, there's further safeguards built into it, wanting to know if the board would consider allowing further allowance for pharmacists not checking. The board did write a rule, became effective January 30th of this year. It's 2.950, called Automated Filling Systems. It covers all of these filling systems. So what is a filling system? It's a system used in a pharmacy, so it's not off-site. It's used in a pharmacy to assist in this filling process. The rule identifies selecting, labeling, filling, or sealing medications. It's the things it does. What they're not counting devices. Some pharmacies have counting devices. That's not what we're talking about, and we're not talking about vacuum tube delivery systems or automated dispensing systems that we previously talked about. The regulation divides these automated filling systems into two types. The first type is what we see the most of, and that's where a pharmacist is verifying everything that comes out of it. The example of the one with no lid, a pharmacist still verifies the final product that comes out of that. There's a variety of different types of units. Different companies sell them. The rule, if a pharmacist is verifying everything that comes out, the rule really doesn't require add any new requirements to you. It does say that the stocking has to be done by licensees, which currently you do because all your staff is licensed in the pharmacy. It has to be under supervision of a pharmacy. That's what you currently do. Other rules require that. And then any repackaging has to be done in compliance with 2.130. Again, that's current. There's no new requirements put on pharmacies that are using these types of systems when a pharmacist is checking everything that comes out. What the rule was written for is the scenarios where a pharmacist is not doing a final product verification. So all the above requirements apply, and then the remaining sections of the rules apply. And I'm going to go through those now. So these are all ones that apply when there's no final verification by a pharmacist. The system must be fully automated. That means after it's loaded, there's no other intervention. When it comes out, it's ready to go to the patient. The pharmacist has verified the prescription data that's being used to generate the prescription. That already currently happens by other rules that are required. The pharmacist verifies the drugs that are loaded in it. So once this just puts into regulation the board's previous interpretation that if a pharmacist verifies the drugs when they're loaded, no further pharmacist verification is required as long as it's fully automated. And what the new rule goes on to do, it adds another allowance, is if electronic verification can be used on manufacturer's unit of use packages or containers or cartridges that have already been repacked and checked by a pharmacist. So when those are loaded, if they're being checked electronically, verified electronically, then a pharmacist is not required to do a final check on those either. So this is a scenario where there would be no pharmacist involved in loading or in the final check, and technology is doing all the checking for you. The requirement requires documentation of the responsible pharmacist for the loading. Other requirements is the system has to have electronic verification that the correct label has been affixed to the correct vial. A new requirement is daily random audits. This requires a pharmacist to perform a verification, and the sample size is 2% of the daily prescriptions filled by the system. A pharmacist has to manually verify those. The sample is determined by the pharmacist in charge. We get questions on this. Is it the first ones that come out? Is it the last one? Does it have to be taken throughout? It's up to the pharmacist in charge to determine how the sample is collected, but 2% of the daily volume has to be checked. And you have to document these audits and the results of such. The system has to be checked before first use and before use after any modifications affecting the filling or any of the electronic verification processes. It requires a policy and procedure manual. It must be written. It must be reviewed by the pharmacist in charge annually. You need to document that. And it basically has to cover all aspects of the system. I went on here and kind of just grouped them together. Again, you need to go to the rule and look at what's actually said. It needs to be in the policy and procedure. But system maintenance, loading, sanitation, cross-contamination of drugs, how you handle expired or any recalled drugs in the system, errors and malfunctions, your testing of it, the training of your staff, access to the system, tracking the people who have access to the system, and then a quality assurance program. Just one caution about automated filling systems. Since this is a new rule, we know we had systems in place prior to the rule. If you're operating one of these systems where a pharmacist is not checking the final product because it's being checked before it goes in, you now have to be in compliance with this rule. You have to be doing the audits, policy and procedure manual, everything that's required. So if you had a system prior to this, you now need to be in compliance with the rule. Okay, that takes care of my program for today. We're now going to answer some of the questions we received.
Okay, my doctor's office has a dispensing machine at her office. Does the Board of Pharmacy regulate it?
The answer is probably not. I'm not aware of any in Missouri that are regulated by us. The ones that are in Missouri are being operated under physician dispensing. There is no pharmacy involved in it, as in filling the prescription. There may be a pharmacist providing counseling via audio or video, but I'm not aware of any in Missouri. They are legal for physicians to operate these, but they have to be operating them under the Board of Healing Arts rules.
If a central fill pharmacy is using an automated filling system, does the 2% audit have to be performed at the central fill site, or could it be performed at the Class J pharmacies?
So what they're asking here is if a central fill who's filling the prescription and then sends them out to, say, the retail stores in their chain, can the pharmacist perform that check at the retail locations? The answer is yes. It has to be documented. The central fill who's operating the thing would have to have access to those audits, but it does not, under a Class J scenario, it could be done at the retail pharmacies.
Can controlled substances be stocked in a multi-med automated dispensing system?
They can be. However, the multi-med rule does not allow controlled substances in multi-med packaging. So you have to be careful here. It could be in the system. The system would not kick them out as multi-med pack. They'd be coming out as single drugs, but they can be stocked there.
If a breach of security occurs at an automated dispensing system, what is the time frame to report it to the Board of Pharmacy?
The rule does not give an actual time frame. I would recommend doing it immediately. Once you have it investigated, let the Board of Pharmacy know. You could either notify the board office or you could notify your inspector.
In the automated dispensing system limit of 3 per pharmacist, is the ADS limit of 3 per pharmacist talking about systems or sites, since some sites have multiple systems?
It is actually it's systems. It's the actual device itself.
Who can restock automated dispensing systems at a long-term care facility? Nurse, pharmacist, technician?
Again, they have to be licensed by the Board of Pharmacy. So if a nurse you want a nurse to do it, they would have to get a Board of Pharmacy technician license.
Can an automated dispensing system be restocked by a nurse at a facility if it is only being used as a to dispense medication e-kits?
As long as it's used only as an e-kit, the answer would be yes. But if it's used for any kind of continued therapy, then our rule would apply that said it could not be.
If you allow a staff member at a long-term care facility to be licensed as a tech, how does that reflect in the tech-pharmacist ratio? Does there have to be any direct supervision by the pharmacist?
The first question about the ratio, Missouri doesn't have ratio, so if you're asking for an out-of-state, because I know we have some out-of-state pharmacies operating these systems, your state may have a ratio. I cannot answer that. You would need to ask your home state. Missouri does not have a tech pharmacist ratio. The direct supervision, the board does allow for the technician to go off-site and to load the machine without a pharmacist being present.
How do the automated dispensing system regulations apply to assisted living facilities? Would their patients be considered outpatients, and then the outpatient rules would apply?
First, you'd have to find out if the assisted living facility is licensed by the Department of Health. If they're licensed by the Department of Health, then a Class N would apply. If they're not licensed by the Department of Health, the system isn't going to be allowed because it wouldn't meet any of our requirements of either being in a licensed facility or at a prescriber's location. So it all goes back to whether the assisted living is licensed by the Department of Health. We have someone asked, they were kicked off momentarily and they got signed back on. Can they still take the test at the end? The answer is yes. It should still pop up for you and allow you to take it. If it doesn't, send us an email and we'll get you the questions.
Can you define inpatient activity in a hospital? We have inpatients and outpatients in different areas. We may have a nursing area that deals with outpatients only.
Okay, the board's definition of inpatient and outpatient doesn't always coincide with what hospitals use for billing purposes. The board's interpretation is if the drug is being administered on-site to the patient, then it is inpatient activity, even though you may have them registered with your billing as outpatients. So it all depends. If the drug's being administered there within the Department of Health licensed premises, it's inpatient. If it's being given to a patient and they're walking out the door with it, then that's outpatient.
Can you clarify the length of time a long-term care facility can use an automated dispensing system e-kit before the Board of Pharmacy would consider the e-kit falling under this rule of continued dosing?
I am not, Department of Health sets the guidelines on that, so that would be a Department of Health. My understanding is it's only to do an emergency period until something that could come from a pharmacy is there. But again, that's the Department of Health that would need to answer that question since they're regulating the facility.
If a system breaks down, who can be present when the service technician arrives to the site? A pharmacy or a pharmacy technician?
It could be someone licensed with the board would be anybody licensed with the board. So a pharmacist, a pharmacy technician, an intern. If they had long-term care staff that got licensed with us, then as long as they're licensed, they would be able to help them.
Assuming the assisted living facility is licensed by the Department of Health, then would the automated dispensing system regulations apply, or would these be considered outpatient?
I guess it depends on what type of system you're using. If the patients are coming directly to the system to get their meds out of it, then my thinking would be that that would be a Class O that's not allowed there, but if the facility staff is the one who is retrieving the meds and then giving it to the patients, I would say that would be a Class N. I'll have to do further research. The asker should probably email me this question so I can get them an answer.
Okay. If you are using an automated filling system for central fill for multiple pharmacies, does just the central fill pharmacy have to have the Class J license, or do all related pharmacies need a Class J as well?
Any pharmacy that the central fill is supplying would need Class J. So most central fills, as everybody involved has Class J on their license.
With the current systems in use in the state of Missouri, what type of feedback are we receiving from the public?
I'm not sure we received any feedback from the public. The systems I'm aware of are located in long-term care facilities, so I'm not sure how much public, if they have any interactions with them at all. So I'm not aware of any feedback from the public.
Did you say if the video is not functioning on the tube delivery system, we could not use the system?
That's correct. The rule specifically says they must be functioning, and functioning means you can see the patient. I have been to places where the quality of the video is so bad you couldn't see the patient. So yes, you need to. If it doesn't, it needs to be shut down and fixed.
Regarding the automated dispensing system used in the healthcare facility, would the medical department within a prison qualify under the facility licensing requirement?
It's a good question, and I do not know the answer to. So I have to research that. The asker should email me that question. I'm not sure if we would consider it depends what kind of prison, a state prison versus a county jail type would also think. I'm not sure if we would consider a jail to be a licensed healthcare facility. So email me that question and I'll research that. Let's see, we're pretty much, I think most of the questions are repeats of what we've already answered. So unless anyone has any more, I think we will wrap up the webinar. Just to let you know, the next Lunch with the Chief Inspector webinar is going to be Thursday, July 17th. It's going to be noon to 1. And then we have another one scheduled for October 15th. I don't remember what day of the week that is. Probably either a Tuesday or a Wednesday. And we haven't set dates for 2015 yet. Just review the continuing education instructions. At the end of the webinar, I will announce that I'm closing the webinar. Do not close your web browser. A window will open up that says the webinar has ended. Close that, and then a survey will then open up. It's 5 questions you need to answer, and then submit them back. We know that smartphones and tablets do not always receive the survey. If you do not receive the survey, you need to email us down at the compliance@pr.mo.gov. The survey, you must get your results back in within 48 hours. If you don't get it and we email them to you, you need to get them back in. And those that are doing it online right now, you need to submit them immediately. We're not honoring survey and email answers coming in after 48 hours. We will mail out certificates in approximately 7 to 10 days. If you have any questions, email compliance@pr.mo.gov. If you don't get our survey, send compliance an email. Again, we will have a recording of this webinar on the board's website in approximately 7 to 10 days. And it's a link to YouTube is where we post them at now. So we are now going to close the webinar.